we will examine the monitor that is used quite frequently, a pulse oximeter. Pulse oximeter gives us peripheral capillary oxygen saturation. So saturation, which is the big S, P, peripheral, O2. It's the percentage of hemoglobin bound to oxygen. It measures non-invasively using a clip method and reflects how well oxygen is being delivered to the tissues. So the SpO2 will estimate arterial oxygen saturation through our oxyhemoglobin dissociation curve, which we'll look at in just a moment. So why do we monitor our SpO2 or pulse oximetry? The SpO2 helps us assess oxygenation of the blood. How well is the blood carrying oxygen? And that is a direct reflection of our respiratory function. Are we able to take in oxygen appropriately? And this can be affected by anesthesia and sedation, which can decrease some of our respiratory function, as well as some of our really sick animals. So we'll often use the pulse oximeter during anesthesia, in animals that have respiratory disease, animals in the critical care unit, and especially during recovery when we're actually taking an animal off of anesthesia. So we're removing 100% oxygen and asking them to breathe room air again. It's important to remember some of the basics of oxygen transport. Oxygen first enters the lungs through respiration and then has to diffuse into the blood from the alveoli into the bloodstream. The oxygen then will bind to hemoglobin on the red blood cells, and these red blood cells will then carry the oxygen to the tissues for cellular respiration, so delivery of oxygen to the tissues. And the pulse oximeter evaluates hemoglobin oxygen binding. So how well is oxygen binding to the hemoglobin? Pulse oximetry is a non-invasive method for monitoring the oxygen carried by hemoglobin in the arterial blood. It is an estimate of arterial hemoglobin saturation, which then is proportional to the arterial oxygen. And again, this will go back to our oxyhemoglobin dissociation curve. The SpO2, pulse rate, and pulse waveform can all be given by the pulse oximeter. And this is derived from light absorption by hemoglobin. What do I mean by that? The principles of the pulse oximeter is that red and infrared light are going to be transmitted through a tissue bed. The oxygenated hemoglobin will absorb more of the infrared light than the red light, where deoxygenated hemoglobin absorbs more of the red light than the oxygenated hemoglobin. A light emitter with red and infrared LEDs will shine through a reasonably translucent site with good blood flow. So we often will put our probes on the toe, the ear, the tongue, a nice tissue bed that those infrared and red lights will be able to shine through. Opposite the emitter is a photodetector that receives the light that is then passed through those tissue beds. Those transmitted signals pass through the tissue beds and are received by the photodetector. The red to infrared ratio is then calculated, and that is proprietary to the monitor's algorithm and is based on sort of a lookup table, empirical formulas that convert that red to infrared ratio to an SpO2 value. There are constant light absorbers, so skin, tissue that is not arterial tissue, venous blood that serves as a background for our SpO2 monitor. So arterial pulsation, the tissues and venous blood are those constant absorbers, whereas the arterial blood volume will change with each heartbeat. So the pulse oximeter is able to isolate the pulsatile signal by noticing the difference between the background absorption and the absorption with the pulsatile signal. So that allows us to get the arterial oxygen saturation, not just saturation in our venous tissues. So it really does give that arterial oxygen saturation. But then it's important that we have good pulsatile flow. And again, I said that the relationship is based on the oxyhemoglobin dissociation curve. So you can see that the PaO2 at the bottom correlates then to the oxygen saturation. So if we expect our PaO2 to be 100, we would expect our saturation to also be at 100%. So a few true or false questions. Pulse oximetry is a good monitor for assessing the adequacy of ventilation. False. The adequacy of ventilation is actually determined by the end-tidal CO2. That is the gold standard for ventilation. That is how well an animal is breathing, not how well they are oxygenating. So those are two different concepts. Pulse oximetry is a good indicator of tissue oxygenation. False. Tissue oxygenation is a multifactorial process where hemoglobin saturation is just one part of that process. Other things involve cardiac output, tissue perfusion, oxygen uptake, so very multifactorial. The pulse oximeter is one of the most foolproof monitors one can use. Well, this is true and false. It's true that it is a simple method to place on a patient, for sure. So it really should be done on every patient that we are doing anesthesia on, at least, and then other animals as well. But there are sources of error. Because we need that pulsatile flow, movement, severe vasoconstriction, even hypovolemia and shock will alter that signal and make it hard for us to determine our SpO2. Pulse oximetry will alert an individual to hypoxemia in a patient. Absolutely. Pulse oximetry is not discriminating for high PaO2s where values on the oxyhemoglobin curve are flat, but once you start getting on the slope of that curve, you absolutely will be alerted to hypoxemia. Complications can occur when using the pulse oximeter. Unfortunately, true. There is a situation where a ferret had a pulse oximeter probe clip placed on its tongue, and the probe was compressive enough to occlude blood flow to the tip of the tongue, and the ferret actually lost the tip of its tongue. But that's a really rare occurrence. So pulse oximeters, easy to use. We just need to know what the data is that we're actually getting.